Okay, well, let me begin with some housekeeping issues for these for this ethics rounds, May 14th. Thank you for joining. CME code today is 15432. These ethics lunch rounds is put on by the Ethical Advisory Committee, and we offer consultations 24/7. This is how you could contact us. You could call my cell phone at the number shown on this slide. You could page the operator, place an order in Epic, or you could get a hold of me by Tiger Connect, and I'm sure to answer that because, as you all know, that will keep on beeping until it gets answered. Again, we offer CME credit, one CME credit. And again, the code is 15432. If you have not yet downloaded the Cloud CME app on your phone, feel free to send me an email and I will give you the CME contact office where you could claim your credit. Okay. And the objectives of this ethics lunch rounds is that upon the completion of the activities, participants should be able to discuss ethical dilemmas in clinical practice and use an ethical framework for solving ethical dilemmas. And these presentations are being taped, and you could, on the intranet, you could click on physicians, and then you'll come to this screen here, and as you can see, we have the ethics lunch rounds presentations. This used to be lunch rounds, and maybe one day we'll be able to offer hybrid events, face-to-face events in combination with virtual offerings as well. Okay, so let's start with the first case. And again, feel free to at any time unmute yourself if you have any questions about anything, but make sure when you unmute yourself, the radio is not playing in the background as well. Okay. All right, so case one, patient with poor neurologic prognosis after PEA arrest. The daughter wishes to pursue compassionate extubation. The son, however, desires aggressive treatment. So the question is, who should be the legally authorized surrogate decision maker? So let's go through the facts of the case and see what we have here. So 60-year-old female with significant past medical history of COPD, hypertension, asthma, was admitted with a witness PEA arrest. Patient is status post targeted temperature management protocol, now even off of sedation. Patient remains unresponsive and intubated. There has not been any neurologic recovery even after sedation was discontinued. Hospital course has been complicated by a retroperitoneal bleed causing hemodynamic instability, leading to shock liver, circulatory instability requiring two pressors. There it is, two pressors, and acute kidney injury leading to acidosis and hyperkalemia with the prospect of dialysis. So we had a family meeting face-to-face with the daughter and virtually with the son, and the patient's potential for neurologic recovery was discussed. It was clearly communicated that the patient's potential for recovery is extremely poor at this time, given the evidence of anoxic brain injury on MRI, in addition to worsening neurological examination over the last few days. It was communicated to the family that the patient likely would not be able to make any so-called meaningful recovery of the mental status. Several options were presented to the patient's family. If the patient were to remain on full treatment, she would likely need 24/7 care in a facility, unable to perform ADLs or interact meaningfully with the family, and would require trach, PEG, and dialysis. The other option would be comfort care measures only after compassionate extubation and DNR status. Now, there is an urgency here because the potassium level is 6.8. So could we reach consensus after an extended discussion among the family? Consensus could not be reached. Patient's daughter and sister expressed their wishes to allow the patient to be comfortable. They wanted compassionate extubation, and they didn't want her to suffer anymore. However, the patient's son expressed disagreement and expressed wishes that everything possible should be done. Son and daughter was agreeable to the DNR, but son stated he was unable to make any more decisions for that day, and he said he would be in the next morning and make any other further decisions. The attending, despite multiple organ failure, thought it was still possible that the patient could survive, and hence thought that further treatments were not medically futile. So what should we do now? So why don't you go to menti.com, use this code that you see, and we have a poll. Should we listen to the daughter, listen to the son, have continued discussions, and in the meantime, start dialysis or go to court? Okay, have continued discussions and begin dialysis. We got 3 votes for that so far. 4, okay. All right, listen to the daughter. Okay, let's have a few more votes. This is, was an EEG done. I'm wanting to say yes, no seizure activity. A few more votes. Maybe I should have put down an undecided option here. Okay. All right, so continue discussions and begin dialysis. Okay. All right, well, actually, there is a Maryland law that says if there is a dispute among legal decision makers of equal priority, then that case has to be referred to the ethics committee to decide who should be the decision maker, and the healthcare provider could follow the recommendation of the ethics committee, and in doing so would receive legal immunity from any subsequent lawsuits. So that's what was done. We called for a consult, and we spoke to the daughter and asked her about her thoughts, and she again said she didn't want her mother to suffer anymore. And she said during the last few days, she would receive phone calls from the hospital, and she just didn't want her mother to suffer anymore and live with tubes and machines. I asked her how to contact her brother, and she said he doesn't have a phone, and she had contacted him by Facebook Messenger during that previous family meeting, but somehow she couldn't be able to contact him now at that time. And I asked her, how come he was not visiting the mother that evening and waiting until tomorrow morning? And she said he probably had other priorities. I spoke to the palliative care NP who thought that the daughter and sister appeared to have a good understanding of the current situation, and however was unsure as to whether the son had a good understanding. I spoke to the clinical nurse who thought that the son did not demonstrate a good understanding of the medical situation, and even admitted to her that he was frequently high on marijuana. Does that give us any more information as regarding who should be the decision maker? So on the chat box, why don't you just say daughter, son, or still undecided? What do you think now? What should we do now? Daughter. All right. So it appears that the daughter. A lot of people are saying the daughter. It certainly did seem like the daughter was more involved. The daughter had been physically present throughout the hospital stay. In contrast, the son has not visited his mother, and never had a visual picture of how she looked, and was using a lot of marijuana. Not that there's anything wrong with that, but one has to wonder whether he's taking all this in. And I was struck by the fact that he was waiting until the next day to come in to see his mother, and hence overall we thought that the son was not an appropriate decision maker, and as such we advised the medical team to listen to the daughter, and the patient did not need dialysis through the night. The next morning, the son called in and said, follow his sister's decision. So the patient was extubated and died peacefully. So thoughts about this case? I think the daughter was the appropriate decision maker, and the son made us all look good with that decisions. Okay. The next case, since we're on this theme about surrogate decision making, we had this other case. We had 57-year-old male presented with history of hypertension, gout, alcohol use disorder, and was found down at a group home, had a CVA and a recent COVID infection, and with his stroke, he had increased midline shift and had a hemicraniotomy, and he had multiple DVTs. The patient has no known next of kin, but he has a girlfriend with whom he has had an online relationship during the last 2 months, but has never met this person in face to face. Now, so be that as it may, according to Maryland law, here's the priority of the surrogates. We have top of the list, guardian, if one has been appointed. Next, the spouse or domestic partner, adult child, parent, brother or sister, or a friend or other relative of the patient. So the law recognizes that a friend could serve as the surrogate decision maker. So my question to you is, what is my question? Right, yes, so what to do now? So go to www.menti.com and I'll show you where the code is. Okay, the code is up here. Here's the code. What should be done now in regards to the decision maker? It's not the poll, but should we accept the girlfriend as the decision maker, or should we do anything else? Listen to the girlfriend, yes or no?
I think there's a good question in the chat box. Has she agreed to make decisions? Like, is this something that's been discussed with her?
Well, should we ask her whether she would be agreeable? Good question. Should we ask her? Should we approach her and tell her you have the opportunity to be the decision maker, and have her sign an affidavit of relationship? So we have no, ask her first, yes. If she feels comfortable, yes. Okay. All right, we have a lot of yeses. If she, yeah, there's no family members available,
There's no advance directive?
no advance directive. Good question. The Maryland law says a friend or other relative of the patient who meets the requirement of paragraph 3 of this subsection. Okay, so let's see what paragraph 3 says, or section 3. The patient, the person has to be a competent individual, presents an affidavit to the attending physician stating that the person is either a relative or a friend, close friend of the patient, and specific facts and circumstances demonstrating that the person has maintained regular contact with the patient sufficient to be familiar with the patient's activities, health, and personal beliefs. So, what do you think about that? And unmute yourself and let me.
Not likely after 2 months of an online relationship to have that level of understanding.
Okay, good thought. Thoughts about that opinion?
I think it's fair. I struggle with this because the alternative is a ward of the state who doesn't know them at all. So I definitely think that's a very valid and reasonable opinion, but if it's not her, then it's going to be someone who's never spoken with him.
So, good thought. So, if you go for a guardian, what would the guardian do in trying to determine what to do?
They'd probably talk to the girlfriend.
Okay, all right, and
I think they'd talk to the physician. Usually they talk to the physician and base it on their recommendations.
right, yeah, right. I mean, they do a fact finding. Other thoughts?
Can we ask the girlfriend if she's had regular contact and feels sufficient and familiar to be able to provide an affidavit?
Well, yeah, we could. Now, but would you still accept her a statement that she feels comfortable?
I think the idea would be to have a conversation that doesn't ask that question until you decide it's appropriate. So you would talk to her about the relationship and what she knows about the person and what she knows about the person's beliefs, how much they know each other. And then if based on that conversation, you feel that this does meet that category, then you would ask that question.
Okay, all right. All right, some good thoughts. And I think, well, it isn't that I think, so sometimes I do that as well. There was a lot of unease with having the girlfriend make life and death decisions for this patient, which with just a brief relationship with the patient. Now, it could have been that they could have had some heavy conversations online, and the thought was whether this would not only be appropriate, but look appropriate in the eyes of other people with the background of a 2 months online relationship. I mean, it could be possible that they had some heavy conversations, and the thought was that one would have the judgment of the court appointing a guardian with some guidance, and the girlfriend could have petitioned the court to be that guardian as well. So we recommended that we go to court and obtain a court-appointed guardian. The girlfriend wasn't sure about making such decisions for the patient. So there's it just we've been having conversations for the past year online, so there's obviously nothing terribly wrong with online conversations, but it's hard to think that one really gets to know the values of a person online. Possible, but it's might be a stretch. So again, a combination of ethics and the law. Any other major thoughts?
What about somebody had mentioned the staff at the group home. I mean, they were asking about the relationship with the girlfriend, but would they actually be eligible for this since they had spent, depending on how long this person had lived at the group home and cared for that person and what they knew of the person?
Good question, and we did inquire, and nobody at the group home was willing to come forth to serve as that close friend. Now, we've had in the past caregivers who had been involved with the patient for years, serve as the close friend for the patient. So what I'm trying to say is that we've had on many occasions where we have the friend serve as the decision maker. And the major thing I wanted to advance with this case is that a friend could serve as the decision maker. the reason why Maryland added a friend to the list, this was about 20 years ago, and the lawmakers were thinking about with the AIDS epidemic at that time, that frequently the patient would have a friend and not a relative who would come forth to make the decisions for the patient. And it has on multiple occasions served us well in terms of decision making. Okay, good.
I have a question.
Yeah.
Was the worry about the girlfriend somehow having a personal gain or maybe being biased somehow? Is that why a court-appointed guardian was better in this case?
I don't think anybody was worried about a bias or personal gain. I think the concern was whether the girlfriend actually could have known the patient well enough in the last, considering the last, with having a relationship for only 2 months.
So what if it was 3 years?
Well, you're asking what would be the threshold, time threshold. And I don't know what the time threshold would be. I think in the final analysis, as a lot of people have said, interrogate or ask the girlfriend what type of conversations they had. I think 3 years would, well, on one hand, 3 years might be enough. On the other hand, as I think more about what you just asked me, even close family members, right, sometimes don't know their relative well enough, right?
Yes.
So, and we don't question the intensity or the closeness of the relative. Let's say a relative flies in from California. They're always doing that and haven't seen the patient for 10 years, right?
Mm-hmm.
But we don't question that, right?
Exactly.
Right. Yeah. So
We do sometimes question it. I mean, if they are making this, sometimes we do. It comes up. Maybe are they in the best interest? So sometimes we do.
yeah. Well, sometimes we do.
Yeah.
I remember one time there was a patient admitted to the ICU from the floor, and the family had made the patient DNR, but the patient was coded on the floor, ended up in the NICU, and they were angry that the patient was coded And I remember distinctly talking with the family in the waiting room. There was like 20 people in that waiting room. And I was explaining about, well, you know, communication issues, and we coded the patient, and they were asking for the ventilator to be withdrawn, and I started questioning the family. I said, I'm willing to withdraw the ventilator, but tell me why. And they started becoming very angry and blah, blah, blah. And then finally, some of the family members said, well, you know, he was not a good person. He would beat us up at family gatherings, blah, blah, blah. And when I heard that, I said, well, I mean, it's difficult for me to take this patient off the ventilator because essentially what I'm hearing, you don't like him. And so that brings up, you know, the issue that, you know, we don't delve into, well, let me back up. We do delve into why you are making this decision. Would it be something the patient would have wanted? So we do try to understand the basis of a family decision in life and death situation. Now, having said that, let's go with this next case. What are the appropriate goals of care?
Before we go to that, can I say one thing about what you just mentioned?
Yeah.
If I were a family member and I had 15 other family members and we decided that we didn't want somebody based on our understanding of that person to not be resuscitated, and then we came and found them resuscitated with a tube in and we asked it to be removed, and we were told there was a communication issue, let me tell you, I would be angry. And for someone to ask me why I'm angry initially, instead of apologizing first, right? I don't find that as an ethical interaction. That's not ethical. They should be angry. Now, you found out behind the anger there was something inappropriate. But again, if I were the family member and that was based on the family's decisions, the understanding of the patient, it's absolutely be appropriate to ask for it and not to be asked why, right? You don't have to ask me why if we all work together to make a decision. I would be saying, why are you asking me why? So it's really important to think about that conversation needs to happen when that DNR status is made. But to think that people wouldn't be angry in that situation makes no sense.
I'm not saying that the family did not have a right to be angry, but I think if I'm going to remove a tube from a patient on the ventilator, I'd like to know the basis of that decision.
Right, but the decision to put the tube in was inappropriate based on what legally was on the dockets. And miscommunication does not mean that it takes more to take the tube out ethically than to put it in inappropriately, right? So it doesn't take more to take the tube out legally or ethically than it does to say don't put the tube in, legally or ethically.
Well, I disagree. I want to know the basis of that decision. It wasn't recorded in the chart, the basis of that decision. And I have an obligation to the patient. And without knowing the basis of a life and death decision, I'm gonna ask why.
I'm not saying you shouldn't ask why, but it's the same question when somebody goes DNR. It's the same series of questions.
Right.
You don't need to discover this when a mistake is made. I mean, if right? I mean, that should be part of the preliminary discussion before anything legally is signed.
I agree, but without knowing the basis of the decision, I'm going to ask why. We could, I'm happy to have further discussions offline about that incident. And I'm happy that you're bringing up these issues. It was unfortunate that the handoff wasn't, well, it wasn't even a handoff. Patient got resuscitated on the floor. And as it turns out, the basis of the decision to withdraw was somewhat suspect. So I'm happy to have further discussions. So if you allow me, let's look at this next case. 59 female Mandarin speaking from China, has history of hypertension, hyperlipidemia, presented and outside hospital in January with respiratory infection, had contact with several members of the family with COVID, and essentially had respiratory failure, got transferred here, and had ECMO cannulation. Okay, so let's see now. Hospital costs significant for no improvement in respiratory failure, and had multiple infections, no neurologic recovery, and remains critically ill with a poor prognosis. And the patient was deemed not to be a lung transplant candidate. So in April, the daughter agreed with continuing current therapy, but no escalation of treatment. Also agreed to DNR code status. And daughter expressed understanding of the severity of her mother's illness and asked about the prospect or the process transporting her mother's body to New York for cremation. However, in May, the daughter, in conjunction with other members of her family, reported that as the patient continues to survive, they are requesting to rescind the DNR order and also rescind the no escalation of treatment, which had included no pressors, no more antibiotics, and no changing of the oxygen circuit. So we had a meeting with the daughter to discuss goals of care, and the daughter mentioned the goal is for the patient to go home. Well, that exemplifies sometimes the problem with asking for goals of care, because sometimes you get an answer like to go home. Now, on one hand, that's an honorable goal to have. The question is it achievable? And the daughter also said, for a reason why she's changing her mind, is that she said she would feel guilty if her mother did not receive any treatment for any new infections. So we had a discussion about the goals of care, and essentially we talked about the patient's condition, not responding to any external stimuli, and not being a candidate for a lung transplant. So essentially we have the situation that the patient is unlikely to ever be liberated from ECMO, and essentially we had good discussion about what would be now, given the current situation, what would be the goal of care. And the daughter said, well, I realized my mother would never wake up, but I want to spend more time with my mother. And we asked her, would this be something that her mother would want? Would she value life in any existence? And she said yes, as per their culture, that they would she would value life in any existence. So what do I have here? Well, what to do now? Don't go to menti.com. It's probably frozen. So what do you think? Either unmute yourself or write in the chat box in terms of continued treatment. Consult hospice, change code status, continue treatment, honor the daughter's wishes, honor culture, palliative care. What is meant by palliative care in this situation? Daughter's wishes should be listened to.
I wonder if there's a way to reconcile the daughter's wish to spend time with her mother as well as trying to figure out, where to go with her care. Because I'm also worried because she spent a month without escalation, which probably means the patient's gotten even worse, during that time period, which would worry me as well.
Yeah, good thought. Actually, the patient has been stable. I mean, would have some drops in, well, no. The patient has been somewhat stable for the last month. And doesn't have kidney failure. No, I mean, the right heart strain isn't clinically significant. Now she's on ECMO.
Didn't you say, though, that it was the daughter was concerned about the infection and not treating the infection? So couldn't the revised goal or order be to offer antibiotics or treat that, but not necessarily changing the DNR status?
Okay, good thought. We, in the interest of time, we modified the no escalation of treatment to include treating new infections for the initial 48 hours. We also changed the no escalation of treatment to include changing the oxygen circuit if it becomes clotted, and we honored the daughter's wishes to spend more time with her mother. But the question I want to ask, and it's been going through my mind, is how long do we do that for if there's no major events? And I guess what I'm asking is it ethically appropriate to continue with treating everything short of a major bleed or sepsis, not responsive to antibiotics? I really want to hear your thoughts in the final 60 seconds. So on one side, we have the daughter, goals of care. Once we unpacked that ambiguous phrase, goals of care, to spend more time with the mother, a very honorable, well-meaning, understanding wish of the daughter, and in the interest of family autonomy, not as strong as patient autonomy, though she said her mother would want that. Is it ethically inappropriate to keep on supporting this patient with the current modification of no escalation of treatment, considering moral distress of providers caring for the patient, resource scarcity, turning down patients for ECMO therapy, which is a justice issue? I
Is there a law to support that?
The short answer is yes. Maryland law, in addition to spelling out what is medically ineffective treatment, it says a physician doesn't have to provide treatment considered to be medically ineffective, or if it's ethically inappropriate. Maryland law defines what is medically ineffective treatment as treatment that will not prevent impending death or will not prevent the further deterioration of the health of the individual, but it does not define what is ethically inappropriate treatment.
I think there's a lot to be said about cultural beliefs and cultural perspective in this case, because the daughter might have said she wants to spend more time, which seems to be her own goal, but I'm pretty sure that is informed by how she grew up and what they believe about death and dying, and about autonomous decision making. I don't know how long they've been in this country and how much they've been assimilated into the Western beliefs, health beliefs, but I think that plays into this scenario very much.
I agree. I agree with that thought. Other thoughts?
It may be that from a cultural perspective, she's not allowed to make decisions for her mother. Not from a legal or a medical perspective, but culturally, that she's not allowed to override her mother's beliefs. And that could be a part of what's happening as well.
It could be her beliefs as well. Other thoughts?
Is this care, or continuation of the care, medically futile? Can we make a determination of that?
Good question. And in fact, the ID person wrote a note saying that treating any infections would be medically futile. And I think that one could say that this patient on ECMO will eventually have a major event. And one could say even treating any infection will not change the ultimate outcome for this patient. And one could say that's medically ineffective. But having said that, so would we then go back to the daughter in a few weeks and say, listen, we're not going to change the oxygen circuit anymore, or we won't treat any new infections?
The daughter seems to have a lot of the guilt and grief kind of all mixed in with this.
Yes.
Especially with the cultural. So maybe the more that, we can lift the burden from her shoulders, maybe that would help. I don't know. I've never sort of figured out a great way to do that for family members that feel that way, but it always seems to be such a complicating issue,
Yeah. You asked a good question that always circulate in my mind, how do we help family members deal with grief in our institution?
I think even before that, the issue is how do we ourselves use language that is realistic and that makes it clear without, we always want to leave this little edge of hope or this little edge of, for instance, the person at the very first case, it's the same thing. Well, they have a chance to live. I mean, yeah, we can say somebody has a chance to live, but if you use language that makes it feel like this is the daughter's decision, when in fact everyone's going to die, so you can't say, well, this looks obvious, but you can be very clear that this is not a sustainable. I mean, you can use language where it's totally out of her hands, and that's ethical, I think, in a lot of cases, because otherwise it makes her feel like she's going to have to make this decision. And do you have to go through the details to say, now we're not going to do this or this? Do you have to make it seem that you're taking something away and you're asking her permission to do that? Is that ethical? I'm not quite sure it is, because it just makes it sound like she has some autonomy that she doesn't have in this situation.
You bring up a lot of good issues. The issue about hope is, in my mind, an unresolved issue. I agree that sometimes we leave the door open for hope. I tend to go towards the side of that, like in this case, there is no hope that the patient will wake up. And I think now one could redirect the hope, just like the goals of care, to something that's achievable. A lot of other people say never give up hope, and I think that could be misinterpreted. I think that in this particular case, we had good discussions. The daughter realizes and accepts the fact that her mother will die soon. And she said, we had a very good discussion. She wants to spend more time with her mom. And my question is, we left it at that the other day. My question is, my short question is, how long do we what's the word? Let that happen, allow that to continue? Or my larger question is, how do we help the daughter let go?
I would say language is so important here. So say to somebody that somebody's lungs don't work anymore, and that we want to make sure we honor how your mother would like to die. Would you like to talk with your family and make a plan around how we can honor her wishes for death that would be a way your family would like that to happen? And you don't have to, then it's not a decision. It's something that she doesn't, I think that's the way you do those things without making somebody feel they're responsible. Then she does the right thing then for what she feels is appropriate. If she says, no way, I want to know what you're talking about, that's a different thing. But if she says, thank you, let me go talk to my family and see how we can arrange the flights of the airplanes and blah, blah. But, if you say there's a chance, then you're always going to be in this position of giving people this sense of
Yeah,
guilt.
we're not saying there's a chance in this case. We all agree that there's no chance. The question is, I agree with you. The question is, how do you manage is not the right word, achieve a peaceful death? What does that look like so that she will carry that memory with her for the rest of her life in a good way, a good death? And
What about,
I think that's what needs to be done. Yes.
I was going to suggest that what if we had the conversation that with the daughter that says that we don't believe that care should be continued, and we would like to reach out to the court to help to make the decision to stop further care so that she doesn't have to make that decision, that we would have an external, if you will, Solomon, unburdening her from having to make that decision and offer her that option to see if she would feel unburdened if a independent entity helped her.
I want to make a point here, Chandana. I think going to the court is one option, but I disagree with that. We're talking about time. In this case, two things come to my mind. We're all mortals, and time is the biggest healer. At this moment, as of today, maybe daughter is not in a position to decide to let go or withdraw care. But two major things, as we see on the screen, is there a resource scarcity? Is there justice that we are talking about? Are we providing any unjust care? I don't think so. If truly we are in a situation of resource scarcity, we can chime that with the family and tell them we are in this paradigm and we need the vent, we need the bed, something like that. But I think if as of today patient is not in critically ill situation, we have to take a step back, wait another 72 hours, and then reapproach the subject. Yes.
She's on it. There is resource scarcity. We're turning down other patients who needs ECMO. Now, I happen to agree with the thought that we should sometimes relieve the burden of decision-making on family, and we don't have to go to court to do that. We could just have a conversation and say that, and I've done that before as well, telling the family that we should do A, B, C, and D. And in fact, at the meeting with the daughter, it was articulated that physicians could make decisions about medical ineffectiveness without asking permission from the family. And I think, I not only think, but I know that a lot of times families, I agree with you, just can't feel like they're the causal agent in someone's death, and they actually appreciate someone else making the decision. And that needs to be, I think, further investigated. In this case, I think that after a few more weeks of spending more time with her mother, she may feel that this might be a better decision for her mother. Time is playing an important role in this case.
I have a question here in terms of the resource scarcity.
Yes.
It's a question. Is it appropriate to tell the family that ECMO is limited in the Baltimore regional area? We have patients who have not been on ECMO for one day. We want to stop it. And I guess my understanding is I'm no expert in ECMO care, but if if ECMO is withdrawn, then her demise is closer. She's going to, without ECMO, she's not going to live.
Right, she will die almost immediately.
So can that be approached, or has that been said, and how, I don't know how the family will take it?
Well, we didn't put on the table taking the patient off the ECMO. We were addressing the issue of her wanting to rescind the DNR status, blah, blah, blah. So we didn't want to jump ahead 5 steps. I think in reference to your other question, I feel uncomfortable talking in stark terms that we need the ECMO machine for somebody else. I don't.
No, I understand. So I might rephrase it. Of course, language is important. Can we say we tried ECMO for 3 weeks or whichever time frame and we are making no progress? So ECMO is futile rather than telling a family that her life is futile.
Well, I don't think anybody was saying her life was futile.
Sorry. Yes, I'm sorry. I didn't mean it that way. But I'm saying instead of life and death issue, we can just say this mode of care, which is ECMO, is no longer improving her status, respiratory status, so we can withdraw ECMO rather than withdrawing care.
Right. But I understand what you're saying. She finds value with the continuation of ECMO, having time with her mother. I just thinking now that if there's a way that we could enhance the time she spends with her mother and is able to begin to say goodbye to her mother, then maybe in a few weeks she'll be in a better frame of mind to say.
Can I ask you one question about the DNR? I mean, I think that might be futile because she will never be able to, just that she can never say no to stopping, rescinding the DNR or whatever, creating DNR. That doesn't mean that she wouldn't be able to plan a funeral if you said, your mom is not going to be able to survive this and we'd like you to be able to plan the death for her that you wish. So can you start to do that? And we'll talk with you, in the next 3 days to see what that would look like for you. And so that she's starting to actively have her goal of care being a good death. What would that look like for your mother? What would your family like? Who would she want to be with her? And so that the goal of care, I mean, it's not, I would not think that time is going to make her sitting in with her mom with ECMO think that she's going to change all of her cultural beliefs if that is part of this. DNR isn't really the first step. The first step is a good death, because I mean, DNR could have created a good death, but if that means her having to make a decision around not giving her mother something, she doesn't want to do that. So if she can start to be giving her mother something, and so you're planning the death with her and talking with her and seeing if other family members want to do that with her, and they want to come and talk about what that would look like in this room, who would be present, and all that. You don't have to give weeks. That's not a weeks type of thing. It might take weeks for people to get their plane tickets, but it might not. And always, it's like you talk about this and then you can always get the pushback of like, no way, what are you talking about? You don't have to talk about taking anything away. It's always about giving something, giving an opportunity to create something for her mother. I mean, I think that's the perspective that often helps change the sense of where things really are, because she was at that place before.
I agree. The issue is not the DNR. She is DNR. The issue is, as you said, how do we make the next few days, weeks meaningful for her? Easier said than done. It is in any healthcare institution. How do we advance that?
Do we have help from, religious leaders, like say a priest or whatever religion, she is?
Buddhist.
So do we have help from, religious leaders in that sect to kind of emotionally support and advise the daughter with regards to?
Well, that's a very good question. I don't, one, I don't know if we have any pastoral care people from the Buddhist religion, but maybe we could get someone from the community to help us out here. And that's a good thought. We need to draw on more resources. This daughter is going to live the rest of her life remembering, we all remember, right, how a family member dies. And we live with that. And I'm just wondering, how do we make the next few days, the next few weeks meaningful for the daughter? Everything has meaning. How do we enhance that? And make this a meaningful experience for her. That's what we have to do.
Yeah, I think even offering grief counseling to the daughter may be helpful.
Yeah. Where do we get that from? Who provides that?
Do you have, don't you have hospice beds in your facility now with seasons? So you could get a palliative consult, and that team could support her with the meaning making in the death. And I would say not to ever say that you're going to withdraw anything, withdraw care, is instead say you're going to shift the focus of care. And I would give her some time, but a limited amount of time to
She
get
doesn't
this
have a manageable
accomplished.
symptom to be moved into general inpatient care for hospice care. She is pretty much being maintained by machines. And you are forgetting that all the members of this care team have a responsibility for wise stewardship of resources. And I'm not trying to be crass or hard, but I think that we should initiate going to the court at some point, because that does take time as well. And if this daughter says she wants 1 more week, 6 more weeks, it's going to come down to us having to withdraw care or not do anything further. And by the way, I have a 26-year-old father of 4 with COVID-19 lung disease who needs ECMO, and he can't get it because this patient is now occupying it. This is a horrible situation. It is the allocation of scarce resources thing that we've feared all along with all of COVID-19. But there has to be some point where we do have to help this patient and this daughter. And one of those ways is going to court, because it does need a timely, it needs a timely end because of the scarce resource issue.
Right, well, that's, exactly. How much more time? But we have to use that time wisely to help the daughter achieve a certain comfort, if I could use that word, comfort level with her mother passing. We have to get her on a pathway to achieve that. And I agree. There's, how much more time do we have her spend more time with her mother? There's a tension here. Not a tension, but there's a balancing that needs to be done. So I appreciate all these thoughts. I think that we can't revisit this issue with the daughter in 2 weeks without having done something for the daughter. And so we have to get outside help, get grief counselors, help the daughter achieve another position in life.
I just have one question. Imagine for a moment that the daughter is just respecting the authority, which is the doctors that are doing something, and she's not going to ever say to stop either to the doctors. What if she's simply waiting for you? What if she's waiting for the medical system, right? She's not going to challenge anything. She's just.
She has challenged.
She has challenged.
To rescind the DNR. She wants antibiotics for the mother. For her mother?
Well, she realized maybe that she had overstepped her daughter role. Do we really know any of the behind the scenes understanding of any of this without having, also you could say to her, do you have somebody in your community that, are you a part of a temple? Is there a monk that you would like to invite to be with you? I mean, she may have the resources sitting right outside of the hospital. So it might be just that simple. Because again, she just doesn't want to be responsible for taking something away, possibly.
So I appreciate everyone spending more time on this patient issue. As I said before, it's been a personal struggle for me to understand how do you weigh a daughter's request for more time with the very real issues of resource scarcity, moral distress for the staff and caring for a patient we all know is going to die, and how do we manage that type of discussions? How do we manage that grief? How do we get the daughter in a better place, frame of mind? So let me say, I hope I'll have an answer of what happened by the next ethics rounds. Thank you. Thank you so much for your thoughts. I really appreciate you guys unmuting yourself and let me know your thoughts. So with that, I wish everyone a good weekend, more pleasant weather, and maybe it does look like the pandemic is easing down for us. So thank you again for your thoughts. If anybody want to continue the conversation, feel free to, you know how to contact me. I appreciate more discussions. Thank you very much.